Hi everyone, welcome back to the immunology series. Now in this lecture, we will talk about how the immune system plays a role in tissue and organ transplants. In particular, we will look at the cellular mechanisms behind transplant rejections.
I need an ambulance. There's been a suicide.
Who's the victim?
So, what you have just seen is a small cutscene from a 2008 movie called 7 Pounds, starring Will Smith. Now, that's way before he gave a punch. Now, in the movie, his character paid for his sin by donating his organ. Now, the movie has a mysterious title, 7 Pounds. I remember I was in pharmacy school watching this movie with my then girlfriend, now my wife, and we wondered if 7 pounds meant the 7 pounds of organs the character donated. Now, anyway, that's a side story you don't have to worry about. Here are the lecture objectives. We will use blood transfusion as an example of tissue transplantation and discuss how an incompatibility of blood group antigens can result in a type 2 hypersensitivity reaction. We will also look at how the body rejects transplanted organs and the 3 different types of transplant rejection mechanisms. And lastly, we will wrap up with an example of how the transplanted tissue attacks the host. So, let's get started. The reason for transplantation is to replace diseased or damaged or lost tissues. Blood is the most common transplanted tissue. Organ transplants are also becoming more frequent and safe with the advancement in rejection prevention medications. There are several factors that impact transplantation. First, transplants must be introduced in a way that allow them to perform their normal physiological functions. Second, health of the recipient and the donor must be maintained during surgery, and after the transplantation process, the recipient's immune system must be prevented from responding to the transplant and causing its rejection. So it's extremely important to match donor and recipient's HLA type properly. Let's first look at blood transfusion. Blood is the most commonly transplanted tissue. Donated blood is provided via intravenous administration into a blood vessel, replacing blood lost during injury or surgery. Whole blood contains erythrocytes or red blood cells, plasma, and platelets. Red blood cells, although they do not have either MHC class 1 or class 2 molecules, they still have other surface antigen, and if it is not matched properly, it can lead to problems. Red blood cells have polymorphic antigens on their surfaces. The 3 antigens A, B, and O give rise to 4 blood types. In addition, there is an additional antigen called the Rh factor. Now, people either have Rh factor or not having an Rh factor, meaning Rh positive or Rh negative. Now, before a blood transfusion that can happen, the donor and the recipients are matched for ABO and Rh factor as well. Here is a simple table that is color-coded and shows type O blood does not have surface antigens, but have anti-A and anti-B antibodies. So type O blood can be donated to all people, but can only receive type O. On the other hand, type AB does not have any anti-A or anti-B antibodies, so they can receive any blood type, but their red blood cells have both A and B surface antigen, so type AB blood can only be given to type AB people. In addition to ABO matching, Rh factor is also required to be matched. The patients that are negative with Rh factor can develop antibodies to Rh factor if exposed to Rh positive blood. This is usually not a problem for blood transfusion because we do screen for that. But the problem arises when a Rh negative mom tries to conceive a child with an Rh positive dad. Because the Rh factor is a dominant trait, the fetus would also be Rh positive. When the fetus is still in the womb, maternal and fetal blood are separated, so it's okay. But at birth, maternal bodies will get exposed to Rh factor from the newborn's blood, and the mom will then develop anti-Rh antibodies. Now the problem is here. The next time when the parents are conceiving a child, the mom's anti-Rh antibodies can cross the placenta blood barrier and attack the unborn fetus, leading to hemolytic diseases or even miscarriage. The science behind blood transfusion reaction is that the incompatibility of blood group antigens cause type 2 hypersensitivity reactions. Anti-A and anti-B antibodies are IgG immunoglobulins. These IgGs binds to blood cell antigens and see them as foreign. The cells undergo complement opsonization and phagocytosis, resulting in the loss of red blood cell. Here is a practice for you to think about it. Now, based on the chart below, which of the following recipients would be ideal for receiving blood from a type A blood donor? Select all that apply. Now, it doesn't count for anything, but let's think about it. Well, type A, it means it has antigens, okay? It has type A antigens, okay? At the same time, it has anti-B antibodies. So, type A can go to type A for sure. How about AB? Yes, AB doesn't have any antibodies in them, so type A can also go into type AB as well. Now let's look at organ transplantation. Organ transplantation can involve donors and recipients. There are three types of organ or tissue grafting. Autograft is tissues transplanted from one site to another on the same person, for example, skin grafts for burns, blood vessel grafts for bypass surgeries. Allograft is something that we are mostly commonly to think of when we think of transplantation. It's tissue transplanted from one person to another person, for example, kidney transplantation. Donor is the person that is giving the tissue, and recipient is the person that is receiving the tissues. Now, notice those terms. We will keep referring to donor and recipient when we discuss this topic in the next couple slides. Xenograft, now on the other hand, is transplantation between different species. It doesn't happen very often, but it did happen once recently. So talk about transplantation between different species. This happened in 2022. So now there was the first pig to human heart transplantation happened at that time, and the pig's heart was genetically modified, presumably genetically modified to maybe express fewer HLA molecules. Okay. Now, and the transplantation surgery went well, and the patient lived for about half of a year. But the patient died later that year due to heart failure from other causes, but not from rejections, according to the disclosed report. The doctors involved in the process believed it was a success. Regardless of any major organ transplantation, the ABO antigens are crucial for successful organ transplantation and must be matched first before anything else. The next factor between donor and recipient is histocompatibility. It is essential to match donor organs to recipients in order for the process to be successful. The idea is to match the HLA between the two as close as possible to decrease the likelihood of the organ being rejected by the recipient. HLA mismatching can result in organ rejection that may make the process of a hypersensitivity reaction, and we will look at it in detail. There are three types of organ rejection: hyperacute, acute, and chronic. These are all host against graft reactions, meaning the recipient's body reject the donated organ. The first type of transplant rejection is called hyperacute. The name suggests it is very fast, being immediate or within 24 hours. This type of rejection is usually caused by pre-existing antibodies against ABO markers as well as the HLA type 1 molecule that is expressed on the endothelial cells of the blood vessels. During organ transplant, in addition to that piece of organ, blood vessels are also being carried over to provide connection. So the surgeons are connecting the blood vessels of the donor organ to the recipient's blood vessel so that the blood can be supplied to the organ. The blood vessels now has two segments. One segment comes from the organ and one segment comes from the recipient. If they carry very different ABO markers and HLA type 1 markers, that would be problematic because these blood vessels are in constant contact with the circulations. They will start to have a very quick response to those existing or pre-existing antibodies. These ABO antibodies would bind to the blood vessel through the graft and start leading to complement activations and also inducing phagocytosis and clotting. The end result leads to hemorrhage of the graft vasculature and therefore destroying the grafted organ. Pre-existing antibodies can come from pregnancy, blood transfusions, or previous transplantation. There is no treatment for hyperacute rejection because it happens very quickly. So the idea is to prevent this type of rejection from happening by doing a very thorough screening before the transplantation procedure. Another type of rejection is called acute rejection. The name suggests it is not as fast as hyperacute rejection. This type of rejection is caused by host effector T cells responding to HLA differences between the donor and the recipients. This process begins with the destruction of the endothelial cells lining the graft tissue, followed by tissue necrosis. During necrosis, cellular content are released in an uncontrolled manner, and eventually that could also lead to organ failure and even death. Acute rejection takes several days to develop. This is very similar to type 4 hypersensitivity reactions, where you have CD8 cells from the recipient against the donor HLA1 and the recipient CD4 T cell against donor HLA2. To prevent acute rejection, we could use something called inductive therapy to pre-treat the recipient with immunosuppressant drugs. We can treat with maintenance and episodic treatment using different immunosuppressants, and such as anti-T cell antibodies or general small molecule immunosuppressants such as cyclosporin. The reason for acute rejection is that when you are transplanting an organ, it carries different cells in addition to the organ tissues. Dendritic cells that are residing in the donor organs are also being transplanted. The donor dendritic cells leaves the organ and go to the secondary lymphoid tissue and present donor antigens to the recipient lymphocyte. It then starts activating recipient T cells and initiate cell-mediated immune response. Once they leave the lymphoid tissue and reach the target organ, it is acting like a type 4 hypersensitivity. Now you can have both cellular response from CD8 T cells starting to attack tissue cells and also having CD4 T cells, in particular Th1 activates macrophage, leading to inflammation, phagocytosis on all the donor tissue cells. These are the mechanisms that lead to acute rejections. The third type of transplant rejection is chronic transplant rejection. The name suggests it takes months to years to happen following the transplantation surgery, and the characteristics of this rejection is shown by having graft arterial occlusion, also known as accelerated or graft arterial sclerosis. the condition continues to block those vessels that connect the donor organ and the blood supply from the recipient. The smooth muscle cells of the vessel continue to proliferate, and also fibroblasts produce more collagen. It narrows the vessel lumen and eventually leads to ischemia, which means not having enough oxygen supplied to the organ and leading to cell death and organ failure eventually. In the left-hand side panel, we have something called direct allorecognition. It is associated with acute rejections. The recipient T cells are directly recognizing the donor antigen presented by the donor dendritic cell. The right-hand side panel, it is an example of indirect allorecognition. This leads to chronic rejection. During this process, some of the carried over donor dendritic cells will eventually die off naturally through apoptosis. The leftover debris acts as an extracellular antigen and is cleaned up by the recipient dendritic cells and macrophages. The donor protein debris gets broken down into small peptides and presented to CD4 via class II molecules. So far, we've seen that trying to match donor and recipient is difficult. However, there is some good news. Some organs, we call them immunologically privileged organs. It means they are easier to be transplanted. The first one is the cornea. Corneas are on the front of our eyes, and they are crucial to be clear so that we can see it clearly. And if there's any inflammation that is happening, that could cloud our vision. So our eyes have evolved with an immunological environment that suppresses inflammation while maintaining some level of protection against pathogens, such as having tears that contain lysozymes and can attack the invading bacteria. In addition to that, inside the eye, the aqueous humor also contains compounds such as TGF-beta, which can cause the resident dendritic cells to downregulate inflammatory cytokines. Because of all these factors, the chances of finding a transplantable cornea are very high. There is about a 90% success rate without HLA matching or immunosuppression. In addition to that, there's also no blood supply to that area, so you don't need to worry about blood vessel rejections. The second organ that is special is the liver. Liver hepatocytes express very low level of HLA-1 protein and almost no HLA class II proteins. So there is no need to match HLA, but you do still need to match the blood type, ABO blood type, because the blood vessels are still carried over from donor to the recipient. After hearing some organs are easier to be transplanted, bone marrow is just the opposite. Now, it is most sensitive to HLA mismatch during transplantation. Bone marrow transplant is still an allogenic transplant that provides recipients with hematopoietic stem cells so that the recipient can make brand new blood cells that were diseased before. Some diseases that can be cured with bone marrow transplants are leukemia, which includes cancers affecting myeloid and lymphoid lineage of white blood cells, and sickle cell disease. When rejection happens with bone marrow, it is a type of graft versus host disease. Now, it can result in donor immune cell attacking healthy recipient tissues. This happens when donor T cells are not completely removed from a bone marrow transplant. These T cells can migrate to the secondary lymphoid tissue and get activated by donor dendritic cells and mature to attack the healthy tissues of the recipient. The target organs that are most involved in graft versus host disease are skin and lungs. So immunosuppressant drugs are needed to prevent it from happening. And lastly, we have some additional information. Now, this is an example of a monoclonal antibody that binds to CD52 that is highly expressed on the surface of lymphocytes. They can activate the complement pathway and lead to receptor-mediated endocytosis. So here we are using the innate cells to clear up adaptive immune cells to increase acceptance of transplant tissues. But the downside is that the recipient's lymphocytes are also depleted, so they are immunosuppressed against other infections. For this reason, transplant patients also have difficulty to mount an immune response against other infections and vaccines.